Welcome to APFED's EOS Support webinar series. Today's webinar is about biologics. My name's Jennifer Roeder, and I'm a communications consultant for APFED. I'll be moderating today's webinar. We're pleased to have Dr. Amy Klion join us today to talk about biologics and eosinophilic disorders. She's a senior clinical investigator and head of the Human Eosinophil section in the Laboratory of Parasitic Diseases at the National Institute of Health, or NIH. Her research program includes basic and translational research related to the role of the eosinophil and eosinophil activation in disease pathogenesis. Welcome, Dr. Klion.
So thanks again for the opportunity to talk to APFED. I've done this before and really enjoyed the questions at the end. Let me share my screen again. So the title I was given was Biologics at Large, which is a very large title. I'm going to try to narrow it down a little bit. First, I should say I have no conflicts of interest, mostly because I work for the government. And none of the drugs that I'm going to be talking about are approved for all types of hypereosinophilic syndromes, except for imatinib and mepolizumab. I have been and am involved in clinical trials using a variety of biologics, but I do not benefit personally from any of those trials. So I'm going to start out with a definition and a description about hypereosinophilic syndrome and how my group defines it, really for the purpose of how does it apply to me, speaking to all of you who probably have a wide variety of eosinophilic disorders. Where I'd like to start is with the evolution of the definition and what we now consider hypereosinophilic syndromes, because that's really changed over time. In the 30s, Loeffler published a report of two patients who had a very typical type of heart involvement called endomyocardial fibrosis. And what you can see here are pictures. Actually, I can try to see it. Laser pointer. So this is a picture of a heart from one of my patients who had a very aggressive type of eosinophilic leukemia, showing the classic findings of endomyocardial fibrosis that were described by Loeffler, with the red arrows pointing to areas of scar in the heart. What's over here on the right is a heart biopsy from a patient who also had endomyocardial fibrosis, and the green staining on the right are granule proteins from eosinophils. This biopsy, however, was from a patient who had a parasitic infection called Loa Loa. And that's really just to illustrate that even though the clinical findings are very similar, these patients had two very, very different diseases. And in fact, the patient on the right was treated for his parasite and got better. In 1975, the first real case series of patients with hypereosinophilic syndrome were put together by Chusa, Dale, West, and Wolf, and this became the landmark definition for a very long time. And they really never intended it to be the definition. They were just describing a set of 14 patients that they had seen, and all of those patients had blood eosinophilia that was higher than 1.5 times 10 to the 9th per liter, or 1,500 per microliter, for longer than 6 months, or they died before 6 months associated with what were thought to be signs and symptoms of eosinophilic disease. They didn't have a known cause like a parasitic infection, and they had presumptive signs of organ involvement from the eosinophils. And so you can see this was a very loose definition, and actually Chusa et al. Even said that in their paper, that they thought that this definition probably included people with eosinophilic leukemia, like the patient whose heart is shown on the left, but didn't have a proven underlying abnormality. And so this was the definition that was used for a very long time for what was called idiopathic hypereosinophilic syndrome. But what we realized was that this definition isn't adequate for a number of reasons. First of all, you don't want to wait 6 months until your patient dies if you can make the diagnosis earlier, and our techniques for being able to diagnose patients have gotten much better. And the other thing is that, do you really want to exclude people with a known cause, because our ability to detect these known causes is changing and the patients present similarly. So over many years, several groups of us got together and came up with what we call a consensus definition. And so the way we've now described hypereosinophilic syndrome is blood eosinophilia. We couldn't come up with a better number than 1.5 times 10 to the 9th per liter, or and that needed to be at least twice, so it's not a lab error, but without the 6 months, or evidence of prominent tissue eosinophilia with blood eosinophilia. So you can imagine a patient with eosinophilic gastrointestinal disease would fit into, may not have an eosinophil count that's 1,500, but they might fit into this definition. And then to make it be a hypereosinophilic syndrome, you have to have some sort of damage or symptoms that are attributable to the eosinophilia. And so this big umbrella definition would actually include the patient with parasitic disease. It would include a wide variety of patients. And so we made a big mess. So once, I think before I talk about how we're trying to solve the mess, I think it's important also to know that the clinical signs and symptoms of hypereosinophilic syndrome are very varied. And if you even use the CHUSIT definition, where you're eliminating people that have known cause, you get a wide variety of organ systems involved. And the top table is from a paper in 1994 by Peter Weller and Bublé. And what they showed was that the organ system involvement, heart, skin, neurologic, lung, were really very varied. Patients had every imaginable type of organ involvement. And we confirmed that Princess Abagu in my group, together with 14 centers with expertise in eosinophilia, confirmed that the clinical manifestations are very varied, with skin being the most common. After that, lung, GI, and then about 20% of patients will ultimately have really serious complications, including heart and nerve involvement. So that just tells you the organ system, but how does that break down? And so more recently, a student in our lab, Nick Kovacs, helped us with a patient-reported outcome study. And what we asked patients to tell us, so what are your symptoms? And then we broke them down into those categories. And what I'd like to point out is that the number one symptom of patients with hypereosinophilic syndrome was fatigue, which doesn't show up anywhere in the organ system involvement, but can be very debilitating. The second most common complaint was itching. Again, is the itching due to the eosinophils? Is itching due to atopic dermatitis or something else? These symptoms are not very specific, and they're very broad and cross all of the different end organ systems. So it's not always so easy to determine whether the symptoms and signs a patient's experiencing are in fact due to the eosinophils. And that's one reason biologics are so interesting. We can start to dissect out some of these questions about what is really due to the eosinophils and what is not, and I'll come back to that. So now that we have this big group of patients who have tons of different underlying causes, how do we break them up? And this is just a pie chart of the cohort that we've seen at the NIH. These are patients that get referred to us for unexplained eosinophilia or an eosinophilic disease. And we've broken them down into these categories that I'll talk about in a little bit, one by one. What you can see is that 15% or so of the patients have an underlying myeloid cause. That means they have an eosinophilic leukemia, like the patient whose heart I showed. About another 15% have normal eosinophils, but they have another blood cell called the lymphocyte, which is driving the eosinophils. There's a big category that we call overlap that I'll talk more about. Associated refers to patients that have an underlying cause like a parasite or a drug reaction that can cause eosinophilic disease, but is really treated very differently. You try to treat it by treating the underlying cause. There's a small group of people that have a familial or hereditary form, and then everybody else is lumped into the idiopathic orange category. So what are these categories? Myeloid hypereosinophilic syndrome or eosinophilic leukemias, the most common is this thing called PDGFR-A positive myeloid disease. That is what that patient with the heart died of. This represents probably 80% or more of eosinophilic leukemias. There are other mutation positive myeloid leukemias. They can be due to PDGFR-B, FGFR1, KIT, JAK2, and a whole bunch of other genes that can be abnormal. As we test more and more genes, we're finding more and more genes to be involved. The clinical features are sometimes due to the eosinophils, as they are in the PDGFRA positive disease, and they're sometimes because these leukemias can involve other lineages. So JAK2 can drive eosinophilia and can cause the very same kind of heart involvement as I showed, but sometimes it can cause the red blood cells to be too high or the platelets to be too high, and other features associated with that. Chronic eosinophilic leukemia, not otherwise specified, is included in this category, and I won't talk about that. That's a more aggressive type of eosinophilic leukemia. And then there are patients that they really look like they should have this disease based on their bone marrow and some of their lab testing, but we can't find the gene that's involved. PDGFRA positive disease, because it's the most common and because it's really exquisitely treatable with a specific drug, is worth mentioning. It's almost all men, although there are some women. Typically, other blood cells, either red blood cells or platelets, are involved. The eosinophils look really ugly. There are early eosinophils in the blood. The spleen gets enlarged. The bone marrow looks very typical. And there are 2 blood tests that are very typically abnormal: serum B12 levels and tryptase levels. The important thing is that 30% mortality at 3 years was what we used to see before the drug called imatinib became available. Now we essentially see no deaths, and many people are cured with imatinib therapy. So this is something that's really important to identify. Lymphocytic variant HES, as I said, is the flip side. This is associated with populations of abnormal T cells. It's equally common in men and women, and there's a predominance of skin manifestations. So itching and skin rashes are very common. Elevated IgE levels are very common. And some of these patients either have lymphoma when they present or will progress to lymphoma. And we think that number is as many as 30%. And what's shown over here on the right is in the left upper corner of this flow cytometry plot is an abnormal population of lymphocytes that have CD4 on their surface, but no CD3. And those abnormal cells are making IL-4, which drives IgE, and IL-5, which drives eosinophils. And the normal T cells in this patient have a very different pattern. Overlap HES is one of the larger categories because we lump a lot of things into this category. We lump single organ eosinophilic disorders that have names like eosinophilic gastrointestinal disease, atopic dermatitis, chronic eosinophilic pneumonia. They involve one organ, but we think that part of the disease is due to the eosinophils, so that's why we group them here. They also can be associated with very high levels of blood eosinophilia, but are not always. The other thing that gets lumped in this category are things like Churg-Strauss vasculitis, which is now known as EGPA, which is a more systemic disease, but can be very difficult to distinguish from idiopathic hypereosinophilic syndrome. And just as an illustration, I put in the box all of the different disorders that can look almost identical that have lung involvement and eosinophilia. So chronic eosinophilic pneumonia, EGPA, allergic bronchopulmonary aspergillosis, eosinophilic asthma, and hypereosinophilic syndrome. If the patient has an elevated blood eosinophil count, these can be very difficult to distinguish. It's important to recognize these disorders because, as many of you know, the approach to therapy can be very different, and not all drugs work for all these different organ systems. And I'll talk about that a little bit more when we get to the biologics. There are some people that have really high eosinophil counts that are fine. We call them hypereosinophilia of unknown significance. And so they have to have that really high eosinophil count. They sometimes have abnormal lymphocyte populations, but they don't require therapy. And this over here, subject 2, is one of our patients. We've now followed him for 40 years since he initially presented. His eosinophil count is usually between 4,000 and 6,000, which is very, very high. He's never been on any therapy, and he's just fine. And so how to recognize these patients is not always so easy, but we know that they exist. His one count that was really low is when he had appendicitis, and that's because fever can make the blood eosinophil count go down. Similarly, there are these families that have eosinophils in the same kind of range where it passes from parent to child. We know that that's due to the fact that they make too much of IL-5, which drives eosinophils. But at least in the 3 families that I follow, they have no clinical manifestations, even though they have the eosinophilia from birth. And many members of the largest family I follow have lived into their late 80s without any problems, not on any therapy. So again, it's important to recognize that this can exist because we have patients all the time who call us with very high eosinophil counts, and the tendency is to treat when maybe you don't need to treat. There's no evidence that there are adverse outcomes. And then finally, as I said at the very beginning, secondary causes can mimic idiopathic hypereosinophilic syndrome. I showed you a case of Loa, which is a helminth, drug reactions, some types of cancers, immunodeficiencies. There are lots of things that can look like idiopathic hypereosinophilic syndrome. And in fact, in that cohort of patients that I showed you that we followed here at NIH, 13% I accepted on the protocol as unexplained eosinophilia, when in fact, when they had a more extensive evaluation, were found to have a driving cause. So it's important to recognize that because we would treat these patients very differently. So I'm not going to say really much more about those patients. And I'm going to move on to section 2, which is why biologics. So the first reason is that conventional therapy for hypereosinophilic syndromes in general is very unsatisfactory, and many of you probably know that. I'm not sure what happened to the numbers on my axis here, but the top is 100%, and this is again from Princess Abagu's study of where 14 centers were involved in providing data. These are the percentages of patients that responded to a given therapy at 1 month. 179 patients got prednisone alone, and you can see a little bit more than 50% had a complete response at a month. And if you look at complete and partial, 85% of people responded to steroids, not too bad. The other 2 conventional agents, hydroxyurea and interferon, maybe a little bit less complete response, around 30%. But if you add in the partial responses, it also doesn't look too bad. Imatinib really only works for the patients with myeloid disease, and so you can see there are very few partial responses. The real problem, though, is that this is a lifelong disease in most cases, and these therapies have a lot of side effects. And so when we look to see, well, what happened to all these patients over time, you can see that almost half of the people on prednisone stopped it, about 40% because it stopped being effective, another 20% because they developed side effects. Hydroxyurea and interferon, more than 3/4 of patients ultimately stopped the drugs for those 2 reasons. And imatinib, the majority of people stopped because of lack of efficacy, again, because it only works in a small subset of patients. So these therapies are not really terrific. And there are some patients shown here by the gray that just don't respond to anything. And so what do you do with them? So there are some theoretical advantages of what we call targeted therapy, of which biologics are included. The first is it presumably attacks the problem at its root. You figure out what the target is and you eliminate it. The other nice thing is there should be, because it's targeted, less off-target effects. So the reason we see a lot of toxicity from steroids is because steroids don't just work on eosinophils, they affect lots of other cells. And this idea of targeted therapy is really where the world is moving right now. There's what's called a precision medicine initiative that was put out by the FDA. And they call this an emerging approach for disease treatment and prevention that takes into account all the different things that go into a person. And the goal of precision medicine is to figure out the right treatment for the right patient. This is obviously easier said than done. There are a lot of eosinophil targeted therapies. The number seems to be increasing exponentially. Some of them target eosinophils directly and some target indirectly. This is just a figure from a recent paper, and you can see that there are drugs that eliminate IL-5 or deplete IL-5. Mepolizumab and reslizumab are the 2 that are commercially available. And so they're essentially taking the food away from the eosinophil, and the eosinophils don't develop in the bone marrow and die. There are drugs that target the eosinophil directly for death. Benralizumab works through the IL-5 receptor. Lirentelimab works through a molecule called Siglec-8. There are things that interfere with eosinophils going into the tissue, like dupilumab and bertelimumab. And then there are some drugs that we don't have any idea exactly how they work that are in development. And I'll talk a little bit about dexpramipexole just because it's very interesting. Mepolizumab is the only eosinophil targeted therapy that's FDA approved for HES in general. Many of the other drugs are approved for specific types, particularly in that overlap category of eosinophilic disorders, but not for HES itself. And the efficacy and safety concerns may be different across the different clinical subtypes that I've talked about, and also between the overlap conditions. So it's really important to understand how the drugs work and what their advantages are. And so that's really the major part of my talk, is going to be which biologic. So I alluded to this, but myeloid features predict treatment response. And the first study that we did in our group, Panisse Corey in my group, looked at responses to steroids. And what she saw was, dividing into those subgroups that we talked about, myeloid patients don't respond to steroids, as shown in the dark gray. And this was statistically significant and had been observed by many people. In contrast, imatinib, which specifically targets that PDGFR-A and PDGFR-B mutations, it worked 100% of the time in our prospective trial, but also in patients that were sent to us from the outside if you had the target mutation. It worked 50% of the time if we thought you should have the mutation, but we didn't detect it. And if your bone marrow and your clinical features really didn't look like a primary myeloid disease, imatinib didn't work at all, and so is not recommended in that situation. The biologics really, because of imatinib and other drugs that are becoming available, there really hasn't been much of a need to use the biologics. I will point out, though, that the couple of cases that have been reported in this compassionate use study, 3 patients with myeloid HES were tried on mepolizumab. None of them had any response at all. And although I'm not showing you the data in our phase 2 study of benralizumab, we enrolled 2 patients with myeloid HES, and neither one of them responded to benralizumab. Because therapies targeting these specific mutations are now available, not just for PDGFR-A and B, but for many of the other mutations, including KIT and JAK2. And these drugs have the potential to be curative. They really are the treatment of choice for the myeloid subtype of HES. And the biologics I'm going to talk from here down really don't apply to this group of patients in general. There may be exceptions, but for right now, that's really all I'm going to say about this subgroup. So I'm going to move on to a case just to illustrate how we choose these drugs and what some of the limitations are. And so this was one of our patients who's a 54-year-old woman when she presented with an 8-year history of eosinophilia, sinus disease, nasal polyps, itching, rash, and shortness of breath. We did a big evaluation. She had no evidence of a myeloid leukemia, but she had a really high eosinophil count, 23,400 per microliter. She also had life-threatening heart involvement. She underwent a valve replacement and a repair of a second valve and was treated with prednisone without any response whatsoever. Her eosinophil count remained elevated. In fact, it went up, and she developed severe tightening of the valve that had been put in and required a second surgery. She was treated with conventional therapy, high-dose steroids, hydroxyurea, Cytoxan, interferon, and didn't respond to any of those agents. So what do you do with a patient like this? Well, we got mepolizumab approved for compassionate use at a very high dose, and I'll talk about that in a second, 750 milligrams IV monthly. So why mepolizumab? I've already said IL-5 is really important for eosinophil development, and it really plays a crucial role in all stages of the eosinophil life cycle. So it's important in their differentiation and maturation into eosinophils in the bone marrow. It's important in their activation and migration to the blood. It's important in their letting loose of their granules and causing tissue damage in the tissues. And so blocking IL-5 or taking advantage of the IL-5 receptor really seemed like the first most reasonable approach. And there are now 3 drugs that target IL-5 or its receptor: mepolizumab, which is made by GlaxoSmithKline, reslizumab from Teva Pharmaceuticals. These 2 drugs are anti-IL-5 antibodies that are quite similar, and benralizumab, which targets the IL-5 receptor alpha. And I'll talk about mepolizumab and benralizumab. I'm not going to talk about reslizumab only because there's very little data in the eosinophilic disorders other than asthma. So the first trial of mepolizumab was actually the first placebo-controlled trial in hypereosinophilic syndrome that used 750 milligrams IV, like what we gave our patient, and it was found to be safe and effective for patients that didn't have the PDGFRA mutation, but had all sorts of hypereosinophilic syndrome. The patients had to be manageable on 20 to 50 milligrams of steroids. So they were steroid responsive, but some of them were not so responsive. And the endpoint was a prednisone dose of less than 10 milligrams a day for more than 8 consecutive weeks, and the study met the endpoint. If you looked at what happened in the long term, once patients were on the open label, what was remarkable was that more than 60% of patients were actually prednisone free at 192 weeks. These were patients, as I said, that all required 20 to 50 milligrams of prednisone to control their disease at trial entry. We then went on to look at compassionate use. And again, you can see that about 60% of the patients who received the drug for compassionate use had a complete response. And these are patients who had to fail 3 therapies and have life-threatening disease. So even in patients that are steroid resistant, this mepolizumab 750 milligrams IV was quite effective in idiopathic disease, maybe a little less effective in the lymphocyte variant. These patients have the highest levels of IL-5 and ineffective in the myeloid variant. The company went on to do a phase 3 study. They opted to move away from the IV formulation and use 300 milligrams sub-Q. That was shown to prevent flares in steroid-responsive hypereosinophilic syndrome. And you can see the figure here. The black line is placebo, the gray line is mepolizumab, and it definitely reduced flares, although didn't eliminate them. And this study led to the FDA approval for mepolizumab for hypereosinophilic syndrome at this dose. Some additional information about mepolizumab. It's been in use now for more than 20 years and has a really excellent safety profile. It's approved for asthma, Churg-Strauss or EGPA, and for chronic sinus disease with polyps. Clinical trials did not show efficacy in reducing symptoms in eosinophilic esophagitis, and development for eosinophilic gastrointestinal diseases was halted. In the phase 3 trial, all the symptoms got better in patients who were asked to report their most bothersome symptoms, except skin. And you can see that here. So on the left is a decrease in score, meaning a decrease would be the patient got better. And so patients who reported abdominal pain, breathing problems, chills and sweats, muscle and joint pain, or sinus disease as their major complaint all got better. But patients who had skin involvement, the placebo in gray and the mepolizumab in black, were identical. And so that's something to keep in mind, because that might lead to your choosing a drug other than mepolizumab for a patient with skin involvement. It also, as I said, may be less effective in steroid-resistant hypereosinophilic syndrome, especially the lymphocytic variant with very high levels of IL-5. There's data to support that I'm not showing you today. And then finally, the company is developing a drug called depemokimab, which is a long-acting IL-5 that will only need to be given every 6 months, and that's currently in clinical trials. So back to our case. So the patient was referred to us on interferon, mepolizumab, and cyclophosphamide IV, and her eosinophil count was still markedly elevated. She had now developed lung infiltrates and very severe pulmonary disease, so she was failing mepolizumab. We stopped the mepolizumab and interferon and enrolled her on a phase 2 placebo-controlled trial of benralizumab for treatment refractory hypereosinophilic syndrome. And so here I just wanted to point out a few of the differences between anti-IL-5 mepolizumab and reslizumab and anti-IL-5 receptor antibody benralizumab. So benralizumab binds to IL-5 receptor, and the one end of the antibody has been altered so that it attracts killer cells in the patient's body that then get rid of the eosinophils themselves. What's nice about this drug is if you look pre-treatment, this is the bone marrow, all these red cells are eosinophils and cells that are going to become eosinophils. Post-treatment, they're gone in the bone marrow. So it has a different mechanism of action, and it has a different effect on eosinophil precursors, which are not depleted by mepolizumab. It also has a difference in terms of eosinophil depletion in the tissues. Benralizumab truly depletes 100% in the tissues. Mepolizumab depletes only about 40 or 50%. In practice, that doesn't seem to be a big deal. Patients often get better despite having some eosinophils left in their tissue, but it is a difference between the two drugs. So our trial showed that benralizumab was well tolerated, even in patients with very high eosinophil counts. The highest count that a patient had on entry to the trial was 30,000. And it was very effective in depleting eosinophils. This graph on the left is our primary endpoint, which was very significant. Most of the people in the benralizumab group, their eosinophil count went to 0 compared to the placebo group, which was a little bit all over the map. And when we looked at tissue, this is the esophagus and stomach from one of our patients, you can see that at week 24, after she had been on 3 doses of benralizumab, looked completely normal with no eosinophils. So we met the primary endpoint at week 13, where we were unblinded to the eosinophil counts. 17 of the 19 patients who were still on study had an eosinophil count less than 50. And at 1 year, 14 patients were still on study despite reduction or discontinuation of their background therapy. And now at 5 to 8 years, 10 of the initial 19 participants are still on benralizumab and still in remission, doing well. So I should say that the patient I presented was one of those patients. She has been on benralizumab now for 7 years and continues in remission, doing beautifully off all of her other drugs. So what are the next steps with IL-5 and IL-5 receptor targeting agents? I still think we haven't really sorted out the dose effect. So mepolizumab is available as 100 milligrams sub-Q for asthma, 300 for HES, and the dose that we used in compassionate use was 700 or 750 IV. It's pretty clear that some patients require higher dose, and some patients with HES respond to 100, and understanding which patient requires which dose is unknown. The other thing that really hasn't been explored is mepolizumab is given as a fixed dose. Reslizumab, which is a very similar drug, is weight-based. And so it might be that in somebody who's very heavy, that you could give more drug giving reslizumab based on weight, but it's only distributed in the blood and not in the tissue to any great degree. So you might do better with reslizumab. That's really unknown. And then benralizumab is available every 8 weeks for asthma. The phase 2 trial was every 4 weeks, and the currently ongoing phase 3 trial is every 4 weeks. So, will every 8 weeks work? We tried that in our patients on the phase 2 trial and were unsuccessful. Most of our patients went back to every 4 weeks. The big elephant in the room is which biologic for which patient. I don't have an answer to that, and I'll show you a little bit more of that data at the end. And then, as I said, there's a novel formulation of mepolizumab. I think that will make things much easier for many patients. Rather than 3 injections every month, they may be able to get a single injection every 6 months. So what else can you do if you want to target eosinophils? Well, you can stop them from going into the tissues where they cause damage. And so there are a lot of agents that have been tried that target what we call chemotaxis, or the ability of the eosinophil to go into the tissues. A whole bunch of them are listed here. Really, the only one that I'm going to talk about is dupilumab, and that's because that's the one that's been approved for a number of eosinophilic disorders, although not for hypereosinophilic syndrome. What are the pros and cons of targeting chemotaxis rather than production in the bone marrow or IL-5? I think that clinical trials have shown that there's significant reduction in tissue eosinophilia leads to improved symptoms in a variety of eosinophil-associated disorders. And so that's good. And so these drugs might be very helpful. Most, but not all, of the clinical manifestations are related to eosinophilic inflammation in the tissues. And so a drug that just blocks migration may not be ideal for some of our patients where they have a very strong production in the bone marrow. And if you block their migration, you might end up with very high levels of blood eosinophilia that could be damaging. And although peripheral eosinophilia has been described with many of these agents that block chemotaxis, it's been transient and asymptomatic in most, but not all cases. So it's really not clear which patients this is safe in and where people sit on this seesaw in terms of production and migration. And I think that's going to be important in deciding which patients might benefit from dupilumab and other similar agents. So dupilumab is a monoclonal antibody to the IL-4 receptor. It blocks two molecules, IL-4 and IL-13. These are important in driving eosinophil trafficking to inflamed tissues. And IL-13 is also very important in what's called fibrosis or scarring in the tissues. And that's one of the things that can be very severe in patients with hypereosinophilic syndromes and can cause really long-lasting problems. Dupilumab's approved for asthma, but not right now for EGPA. It's approved for atopic dermatitis, chronic rhinosinusitis with nasal polyps, and for eosinophilic esophagitis. It's approved at different doses for all of these disorders, which is a little bit confusing. It is the most effective of the biologics for the treatment of nasal polyps and sinusitis, and it is the only biologic approved for eosinophilic esophagitis. And I'll show you a little bit of that data in a second. It is associated with a transient increase in blood eosinophil count, and there have been cases of eosinophilic complications reported. It should be noted that the clinical trials of dupilumab excluded patients with hypereosinophilic syndrome. So we don't know if these problems would be increased if you treated patients with very high levels of eosinophils to start. This is just the data from the New England Journal paper from Dellin et al. Showing that it is effective in EoE. On the left, really, this was the first drug to show that there was symptomatic improvement with a biologic in EoE. And you can see here at the beginning, it's placebo versus dupilumab. There is no change in the solid line, which is placebo, but the dupilumab patients get better. And then on dupilumab and dupilumab, they sustain that effect. The histologic remission, so the tissue, you can see placebo in the blue, and the orange-ish color or brown color is dupilumab. The percentage of patients that their tissue looked better was dramatically higher in the patients who got dupilumab, both in the two different parts of the study and also at 1 year. So this drug really looks terrific for eosinophilic esophagitis. I think a big question is whether patients with very high eosinophil counts, as some people have with other types of eosinophilic gastrointestinal disease, will have an increased risk of side effects, and that's not known. So I just wanted to make this point one more time because it is real, and tell you about another patient that we saw a couple of years ago. This was a 58-year-old man with a lifelong history of allergic rhinitis or seasonal allergies, mild asthma, and severe eczema with recurrent infections and cellulitis. His eosinophil count actually in 2017 was pretty normal on just topical steroids. He was started on dupilumab for his eczema every 2 weeks, 300 milligrams in 2018, because his itching got worse, even though he was on prednisone, methotrexate, and a variety of topical therapies. After being on the dupilumab, his eosinophil count was checked and it was found to be elevated at 2,320. Because he had persistent symptoms, his dupilumab dose was increased to 600 milligrams every 2 weeks. And then about a little less than 6 months later, he was admitted to the hospital for severe itching, diarrhea, and weight loss. His eosinophil at that point had risen to almost 13,000. His dupilumab was stopped and he was treated with steroids and did quite a bit better. At this point, he was referred to us for further evaluation and treatment of his hypereosinophilic syndrome. At the time of his visit, he admitted that he had taken a dose of dupilumab because his itching was intolerable and he had some at home. It didn't help, and his labs again showed a very high eosinophil count. We did a big evaluation, including a chest CT scan, and he now had a pleural effusion, so fluid around his lung that was full of eosinophils. This was attributed to the dupilumab. Mepolizumab was thought to be unlikely to work. Benralizumab was not available at that time. And this patient is now on a clinical trial of a drug called ruxolitinib, which is a JAK inhibitor, is doing quite well. But I think this just points out that really in a patient with a very strong driving force for eosinophils, you can have eosinophilic complications. And there are examples of this in the literature as well. So what about other ways to target eosinophils? Well, you can target their development in the bone marrow. That would seem to be really attacking them at their source. And there are a number of ways that can be done. The numbers should be different, but I'm going to talk about them in a different order than they're listed here. So molecules like IL-33, TSLP, ST2, which is the receptor for IL-33, these are all involved in the development of eosinophil precursors to eosinophils in the bone marrow. There are also transcription factor inhibitors that are being developed that I won't talk about that can do that. And then there's this one weird drug, dexpramipexole, which I'll talk about for a second. And so the idea is if you block it here, then they're not going to go into the blood and they're not going to go into the tissue. And that would be ideal. So TSLP is actually a target to which a drug has been developed and that is now FDA approved for asthma, tezepelumab. TSLP acts mostly on cells called ILC2s that then make IL-5 and then cause eosinophils to increase. It also likely has direct effects on eosinophils, making them live longer and be more activated. Although tezepelumab has not been studied directly in an hypereosinophilic syndrome, if you look at the trials from asthma, what you can see is that it does decrease the blood eosinophils. And in one study where they looked, it actually decreased the tissue eosinophils when the lungs were challenged with an allergen. So I think this is a very promising agent for the treatment of eosinophilic disease. Right now, really almost all of the data comes from asthma, but that's one to keep your eyes out for. And because it's FDA approved for an indication, and many people with HES have asthma, I would predict that there will be people treated with this drug. IL-33 and ST2 biologics are in clinical development. They haven't done quite as well as tezepelumab. IL-33 also increases production of IL-5 by these ILC cells and to a lesser degree by eosinophils themselves. It also upregulates the receptor on early eosinophils and causes eosinophils to expand. There are a whole bunch of drugs that have been developed. I looked at 3 for which I could find nice clinical trials. And if you look, even though, again, one was a trial in atopic dermatitis, one was in chronic obstructive pulmonary disease, and one was in asthma, if you look at the data, they all reduced eosinophil counts in the blood when it was looked at. So again, I don't know what's going to happen with these drugs. None of them, as far as I'm aware, are currently FDA approved, but if they are, they may be effective against eosinophils. Dexpramipexole is this very peculiar drug. It's a small molecule. It's not a biologic, but I thought I'd include it just because it's so interesting. It was used to treat Parkinson's. It's the right-sided, what they call, it's the flip of a drug that was used to treat Parkinson's disease, and it was found to be neuroprotective in vitro assays. Nobody knows how it works. It was tried in ALS, and it looked really good in the phase 2 trial, but it failed in the phase 3 trial. At that point, the company thought, well, this drug is non-toxic, what else could it work for? And they found that it dramatically reduced blood eosinophil counts. We then used it in a phase 2 pilot trial and met our steroid-sparing primary endpoint. So it lowered eosinophils in patients with HES. It went on to be used in a phase 2 randomized placebo-controlled trial in moderate to severe asthma, where it not only got rid of the eosinophils in the majority of patients, but it also improved their breathing. And it's currently in a phase 3 trial in asthma. This is a very novel drug. It does have an unknown target, but it is a targeted drug at eosinophils. It doesn't affect any of the other blood cells. And I think that, there is room for non-biologics in the targeted therapy armamentarium. And this is just some figures from our paper. This is a patient who was enrolled on the trial. She was 35, had what we call HES EGPA overlap. She was on 15 milligrams of prednisone, had lung, gastrointestinal, skin, and sinus involvement. The gray is her steroid dose. You can see the black is her eosinophil count. Her eosinophil count went to 0 at 1 month. We slowly tapered her steroids after 3 months to 0. And she remained asymptomatic just on this pill for 3 years and 11 months with her eosinophil count 0. Her tissue biopsies looked awful before, they looked much better after, and her bone marrow was completely missing eosinophils, but did have early eosinophils called promyelocytes. What about other biologics targeting eosinophils? The only one I'm really going to mention is lirentelimab, made by Allakos. So there's a molecule on eosinophils called Siglec-8. This is an inhibitory receptor. It's also on basophils and mast cells. It's known that if you cross-link, so if you bind together 2 molecules of Siglec-8, you cause the eosinophils to die. It also causes mast cells to stop releasing their granules. And so this is a really exciting drug because it targets 2 cells that can be involved in some of these disorders. A drug was developed called lirentelimab. It is afucosylated like benralizumab. It binds Siglec-8 and then it targets cells that have Siglec-8 eosinophils and to a lesser degree basophils to be killed. A placebo-controlled phase 2 study in eosinophilic gastritis and duodenitis looked really good. The tissue eosinophils went down by 86% and the symptoms improved. This was published by Dellin et al. In the New England Journal in 2020. Adverse events were pretty similar between the 2 groups. This drug is given IV, and there were some mild to moderate infusion reactions, but none of them were fatal or super severe. They were more common in the patients who got lirentelimab. Unfortunately, the phase 3 trial didn't meet the primary endpoint, and they, as far as I know, have stopped development for that indication, but clinical trials are ongoing in atopic dermatitis and chronic urticaria or hives. So this drug isn't done yet, and we may see it approved for other indications. We had patients on the phase 2 trial that did really well on this drug, and so it may be useful for patients even though it doesn't get approved for that indication. So what about safety of biologics? There's been a lot of talk about whether depleting eosinophils completely is a problem, and in mice, there are a bunch of things that happen. Interestingly, we had a mother, she wasn't a mother at the time, we had a patient on our benralizumab trial get pregnant. She had not been able to conceive previously, probably because she was so sick. And so when she found out she was pregnant, she didn't want us to stop the benralizumab. We got permission from the company to continue. And so her baby was exposed to benralizumab before it was born, while it was in utero, and at the time of birth. When the baby was born, she had no eosinophils for about 4 months. And then at month 9, her eosinophils came back. She's completely normal. She's now 4 years old, normal growth, normal development. We've looked for a number of things that were abnormal in the mice that had no eosinophils, and we've seen no abnormalities in this baby. So I think that's very encouraging data suggesting that even though I think eosinophils are the most important cell in the world, they may not be as important as I think. I think it's important to recognize, as I've said a couple of times now, that interference with eosinophil trafficking is associated with a transient increase in eosinophilia. This on the right is from one of the asthma trials. And what you can see, the green dots are the dupilumab patients and the black dots are the placebo patients. Over the course of the trial, there was an increase in eosinophil counts among some of the dupilumab patients, not all of them, but this is a known finding. And that was in patients who were excluded if they had HES. And then finally, targeting multiple pathways, as with lirentelimab, or targeting different lineages with 2 biologics at the same time, we don't really know what that's going to do. I've told you that eosinophil depletion alone isn't a problem, and that may be because other cells fill in the gap. And so if you take out another cell type, what's that going to do over the long term? And I really think we don't know the answer to that question. So what are the factors to consider when choosing a biologic if you have an eosinophilic disorder? I would argue that the type of HES you have is important, and probably the pattern of clinical involvement. So if you have skin involvement, I might not pick mepolizumab. If you have sinus involvement, I might pick dupilumab. I think thinking about those things is important. Similarly, concomitant conditions. So those diseases may not always be part of the eosinophilic disorder, but lots of people have sinus disease, asthma, food allergies, and thinking about which drug might work for them as well. So you only have to give one drug is important. How's the drug given? Is it IV or subcutaneous? Does the doctor have to administer it? Do you have to go to the hospital, or can you give it to yourself at home? How often do you have to give it? Weekly, every other week, monthly, every other month? All of those things are important to patients and should be important to physicians. What are the potential side effects? They're generally pretty few with biologics, but there are some specific things that have been reported with different drugs. And so paying attention to those, especially in patients who have underlying other disorders. What will the insurance pay for? And I put my frown face here because that's unfortunately probably the most important factor, and it shouldn't be a factor at all. The role of serum IL-5 levels is really very controversial. We don't measure them here except for research purposes. There's lots of data showing that actually, for instance, mepolizumab, patients who had detectable IL-5 levels were more likely to respond than people without detectable IL-5 levels. But then there's this suggestion that patients with very high levels may overwhelm the amount of antibody that we can give with current dosing. So I'm not sure that they necessarily reflect total IL-5 in the body, and I don't think that they're particularly helpful in most cases. So we're left with which therapy to use for which patient. And this is just one figure, and it's meant to look really confusing, from a recent paper that was put together by a whole group of us, again, a retrospective study from a whole group of centers that have expertise in hypereosinophilic syndromes. We collected all our data, put it together, and this figure was meant to show patients who switched from one drug to another. And the blue arrows are if they switched and the second drug worked better, and the red arrows are it didn't work better. And what you can see is there are arrows that go all different directions. So mepolizumab to reslizumab is red and blue because 2 patients got better when they switched from mepolizumab to reslizumab and 1 didn't. You can see the same thing here with omalizumab and mepolizumab, dupilumab, unclear. 1 person got better, going from mepolizumab to dupilumab. One person that failed dupilumab didn't get better on mepolizumab. This is a mess. We really need better data. Unfortunately, it's really hard to get companies to compare side by side. That said, I will say there's an ongoing trial in EGPA comparing mepolizumab to benralizumab, and I really think that those kinds of trials are important. So in conclusion, I think because of the way that I've chosen to define hypereosinophilic syndromes, it's a very variable heterogeneous disorder, which has a lot of different types of causes. They overlap in clinical presentation, but they may differ in response to therapy. And so doing the right diagnostic tests and figuring out where your patient fits in is really important. And although the eosinophil targeted therapies, especially biologics, offer the promise of less toxic, more effective treatment for HES, there are lots of unresolved questions about how to choose the best one and whether there really is long-term safety. The one thing that I've chosen to mostly ignore is cost. And monoclonal antibodies are more expensive to make than most other types of therapies. There's a lot of controls that go into making them and making sure that you're not injecting something that's dangerous. And so although I think cost will come down over time, it's unlikely to be cheap like prednisone or some of the other oral agents. And so this is my current group. I'd just like to thank all the people listed here who've been my collaborators, our clinical group, past members of the human eosinophil section that performed some of the studies that I showed, and of course our patients, without whom I would not have a job. Thanks very much. I'm happy to take questions.
Thank you so much for such an in-depth presentation about all the different options that are out there today, as well as some that are still being explored. For everyone who's listening today, if you are interested in participating in a clinical trial to help us continue learning more about biologics, please head over to APFED's website at apfed.org. Check out under research the clinical trials page. You can see a whole listing of different trials that are open, and they're sorted by different conditions. And so, as Dr. Klion alluded to, your participation in trials can really help us learn a lot more so that we can share more information. But yeah, alrighty. We've got some really good questions that have come in today, and you hit on one as you were closing there. They want to know about insurance coverage and biologics. Is that something you can touch on? I know you had your frowny face up there.
Yeah, I can. I mean, so I'm very fortunate. Part of the reason that I'm at NIH working for a somewhat low salary is because I don't have to deal with insurance. When we provide drug, it's free. Your tax dollars pay for it. That said, we often recommend therapies. And although I'm not directly involved, I see how difficult it is to get insurance to cover even diseases that are the drug is FDA approved for. So for HES EGPA, really the only biologic that is currently approved is mepolizumab. And you should be able to get insurance to cover it. It is the only drug approved for that indication. That said, I know that insurance companies try to get out of it, and you really your doctor really has to know how to argue properly with the company to be able to get them to pay for it oftentimes. I don't know if that'll get better or not. It's frustrating for all of us.
So we've got some other questions coming in about stopping prednisone and steroids when you're on biologics. You talked about, in some cases, people being able to come off of that. So I kind of got a two-part question. How long after starting a biologic can you stop using steroids? And if you try to get off them and have issues like adrenal insufficiency, do you have any advice?
Yeah, so that's a really common problem. So in theory, if you start on a biologic and your eosinophil count goes completely to zero and clinically you are improved, which happens sometimes especially with patients with pulmonary involvement, we've seen people within 2 days, they're like, I feel great. So theoretically, you could stop the steroids. In reality, you can't, because most people have been on steroids for a long time. And so we're kind of forced to slowly taper the steroids off. But if in cases, and it does happen sometimes, where someone's only been on steroids for a very short period of time, you could stop them right away. There's no risk. In someone who's been on them for a long time, you taper them down very slowly. You have to be very vigilant for adrenal insufficiency. If the patient has adrenal insufficiency, what we normally do is we switch people over to hydrocortisone, to what's considered a replacement steroid. They're all steroids, but we're giving the amount of steroids in the form that your body would normally make to your body. And so it's generally not associated with as much in the way of steroid side effects. But patients that have adrenal insufficiency need to sometimes take additional steroids like prednisone under stress, because your body would normally make stress steroids, but if it's not making steroids, then we have to do that artificially. So that's something that really needs to be managed by an endocrinologist with the patient. And you need to be very careful. Adrenal insufficiency can be fatal.
When you're on a biologic, are there any precautions that you need to take, or significant side effects that you should be looking out for?
Not that we've really seen. I mean, I can tell you what's in package inserts. So for whatever reason, in the package insert for mepolizumab, the FDA had them put in a warning about zoster, shingles. That was based on, I would argue, very weak data. However, because it's in the package insert, people getting put on mepolizumab should probably get the zoster vaccine. But we really haven't seen an excess with that drug. And I would think if it were due to the drug lowering eosinophils, then you would see it with the other eosinophil lowering drugs, and it's not in their package insert. Dupilumab has some unique side effects in terms of conjunctivitis and things. And so, yes, you should be aware of that. If you have a high eosinophil count, I would monitor that very closely, especially in the first 6 months of being on dupilumab, to make sure that it doesn't go up higher and you don't have side effects. But in general, these drugs are really safe, and most people don't have much in the way of anything.
How long can you stay on a biologic? And is there an issue if you stop?
So we don't know. I mean, that we have patients. In fact, I saw a patient today who was on the original placebo-controlled HES trial. So he was put on drug in 2000. So 23 years. And so we have patients that have been on drug 23 years. So, but that's the longest and the drug for which we have the most data. Most of the other agents, you have to think back to, well, when did they start clinical trials? So we don't really have data longer than that. We don't know whether there'll be long-term problems, but we haven't seen any. And people have looked pretty carefully for like development of cancers, autoimmune diseases. It doesn't seem to be associated with these drugs, but can't be excluded. Can you stop is a very interesting question. I do have 3 patients who were on that original trial of mepolizumab, who, for whatever reason, we were able to extend out their dose and extend and extend and extend, and then we stopped it, and their disease hasn't come back. HES rarely goes away on its own anyway. Is that what happened, or did the drug make it go away? I don't really know. That is very uncommon. Usually what happens when you stop is the disease comes back. But we're not aware that doing that causes resistance. It can cause rebound, so you can get sicker than you were before you got put on drugs. So you have to be aware. If you had heart involvement, I would not stop the drug, because that can occur very quickly and you wouldn't want that to happen. But if the disease was more mild, you can try and stop it, but it may come back.
I have 2 follow-up questions on that. There's an acronym. I'm going to lean on you to hopefully know what it means that they've put in their question. Is there a relationship between long-term biologics and NTM infection?
Interesting question. We don't know. That's non-tuberculous mycobacteria. So TB, but not TB.
Okay.
So I follow a number of patients on biologics that have non-tuberculous mycobacteria. However, it's really not clear whether the two are related, and I can come up with other reasons that each of those patients has non-tuberculous mycobacteria. I also had a patient develop tuberculosis on mepolizumab, but I don't think it was related. So I don't know. In vitro in my lab is actively studying this. We're looking at mycobacteria and eosinophils. Eosinophils do seem to be important to some degree in fighting mycobacteria, but we just haven't, it's not a huge problem, and we really haven't seen anything to support a major concern. We don't screen for it before we put people on.
So the other follow-up about side effects is about the eye side effects. So they said, to what do you attribute the eye side effects which arise with dupilumab?
I wish I knew. I have no idea. It's observed. There may be people that know. I haven't been involved in any of the clinical trials of dupilumab. I'm a little bit less knowledgeable about the side effects of that drug, although we're starting to use it now. But I don't know that it's known why it does that.
Gotcha. So people are very impressed with your knowledge and writing in lots of very nice comments. And one of them even wants to know, how does someone get seen by NIH, such as your team?
So that's pretty easy. I mean, the way I would say about probably 80% we get contacted either by the patient or by their doctor. I have an unusual name. I'm very easy to find. I mean, if you search my name on Google, I'm Klion@nih.gov. So very often what happens is the person directly contacts me. I refer their voicemail or their email to our study coordinators. The NIH, we only see patients on research protocols. We do have what we call a natural history protocol to evaluate patients. We use that protocol in several ways. So first, we review records. If we think the person is getting appropriate care, we have nothing to offer them, and they don't have something peculiar that we're interested in, then oftentimes we'll just give recommendations. If we think that we have something to offer, or we have a clinical trial running, we have a number of clinical trials, one for ruxolitinib, we're running the benralizumab phase 3. So if we have a clinical trial that the person would qualify for, or if they have a particular type of hypereosinophilic syndrome that we're very interested in at the time, then we would offer that patient to be seen. And like I said, it's free to be seen here, but you have to get here the first time. Although we do have ways, if somebody really doesn't have the money, to bring people and pay for their travel. And so we see a fair number of patients. We're a small team. We can't see everybody, but we're always happy to review records and give advice.
Okay. You've talked a lot about ATS today. And so we had a question that come in, and we'd love for you to provide some clarification. Is ATS different from an EGID? Is ATS considered an EGID? What's the difference between EOE, eosinophilic colitis? Like, they're trying to wrap their heads around the spectrum of EOS diseases.
Yeah, so it depends who you talk to. So and that's true for any of these, what we call overlap. In my group, we really take the approach that eosinophil-driven diseases, or diseases where eosinophils are playing a part in the signs and symptoms, fall under that big umbrella of HES. So they're a type of HES, but they're a very special type. And I would argue that pure EOE is very different than some of the other EGIDs. Eosinophilic colitis and EOE are just about as different as EOE and eosinophilic pneumonia. So we view them all as part of this big umbrella, but we approach each of them differently. And I think that's even more important with the biologics, because they're working at a mechanism, and the mechanism underlying all these different eosinophil-associated disorders may all be the same. It may be different, and the drugs are actually helping us understand that. So the fact that EOE didn't get better with mepolizumab, but asthma did, tells you something about what eosinophils are doing in the GI tract in EOE and the involvement maybe of other cells. So I would view it as an independent entity. It's an EGID, it's its own thing. But I put it under the big umbrella because sometimes you can't tell where people fit in exactly.
Well, thank you so much for all this wonderful information. I know we've gone a little bit over the scheduled hour time. We really appreciate your extra time. No, we appreciate your time to stay longer to answer more questions. But I do want to be respectful and know you have some other things this afternoon we need to let you get to. So
Thanks very much.
Share my screen here and take a turn. Alrighty, so in addition to thanking Dr. Klion for her wonderful presentation today, I also want to make sure we take an opportunity to thank our education's partner that make APFED's EOS support webinar series possible. That includes AstraZeneca, Bristol Myers Squibb, GSK, Sanofi, and Regeneron. We hope you will join us for more webinars in the future. The next one is on May 19th, and it's going to be the first in a two-part series about emerging diagnostic tools for EOE. This first one in the series is going to be focused on unsedated transnasal endoscopy. So join us on May 19th at 1 o'clock. You can register at apfed.org/webinars. Our three panelists will start by giving us an overview of the diagnostic tools that are available and then have a really focused discussion on unsedated transnasal endoscopy. We also hope you'll register for APFED's annual patient education conference, EOS Connection. This year, we're headed to Denver, Colorado, or you can join us online from anywhere. We have a virtual conference environment that you'll be able to participate in. We also have many different opportunities to connect with people and to continue learning. We have our podcast series called Real Talk Eosinophilic Diseases. Check out the most recent episode to learn more about EGPA. We talked with Ashley Spencer, who is a patient advocate, about her experiences. We think you'll really enjoy listening to that. You can check it out on apfed.org/podcast, as well as Apple Podcasts, Spotify, Audible, and more. If you want to make direct connections with other patients and caregivers, in addition to attending our conference, you can also join our online community at apfed.org/connections. So thank you again to everyone for joining us today. We encourage you to check out apfed.org's website to be able to explore clinical trials, and also know that we are continuing to educate people and advocate for access to things like biologics. We know there are lots of questions outstanding with what they cost, how to get access, insurance, etc., and know that APFED is advocating for access and patient needs and trying to educate those insurance companies. So if you have a question that didn't get answered today, please email mail@apfed.org, and please join me in thanking Dr. Klion for joining us again today.
Thanks so much.
Absolutely. I hope everyone has a great day.